Thank you for joining us for this valuable webinar today from Synron Candela. Today we will be presenting about picosecond technology, discovering the facts, and debunking opinions. Our special guest speaker is Dr. Ophir Artzi, who heads the Center for Aesthetic Dermatology at the Department of Dermatology, Tel Aviv Medical Center. The Center for Aesthetic Dermatology is at the forefront of treatment, teaching, and research in aesthetic dermatology. Dr. Artzi is a member of many national and international dermatological and cosmetic professional associations, participates in many professional forums, and has been honored as a guest speaker at numerous national and international aesthetic and dermatologic conferences. With that, I am pleased to introduce Dr. Artzi.
So good evening, everyone. It's great being here, and this webinar is broadcasted from Tel Aviv, Israel. This is my disclosure. A few words about myself. I'm a dermatologist. I had probably the biggest center for aesthetic dermatology, which is hospital-based, and I have two private clinics, two big private clinics. One is in Tel Aviv and one in Jerusalem. And I have been using the PicoWay, the Picosecond laser for the last 3.5 years. And I'll try my best to share my experience and the protocols that I use. In this webinar, we're trying to have some time view of laser technology, mainly talking about pigmented lesion and pulse duration. I'll try to refute a few myths and to debunk opinions. But mainly, I'll talk about my experience using the PicoWay in my clinic, and I will not talk about tattoos. So I will focus on the non-tattoos dermatological indication, and I will share with you some publications that we've done and some works that are going to be published. So I'm sure it's going to be interesting. To begin with, if we go back into history, lasers and pigmented lesions, they weren't very good friends. So back in the beginning of history, I'm talking about the history of lasers, if you treat pigmented lesions with laser, and we're talking about the continuous wave lasers, we had many complications, mainly scars. I think it wasn't until 1983 when Rox Anderson came with the concept of selective photothermolysis. And we now know that if we have certain wavelengths that reach certain depth and it is absorbed within a certain chromophore, if we have pulse duration which is shorter or equal to the TRT, and if we have enough energy, not too much and not too little, then boom, we can have an effect. And there was a change. So if you look, I talked about the 1960s. We started with continuous wave, then we got to millisecond, and then we got shorter and shorter. We're talking about the nanosecond laser with the Q-switch lasers, and from 2012, this is the first picosecond laser that came into the market. Nowadays, wherever you go, in every conference, we have many studies and many lectures talking about the picosecond lasers, different wavelengths. We all know that we have, in general, for the people who are less familiar with picosecond laser, we have lasers which create pulse of less than 1 nanosecond. And why it is important? Because if you look, the shorter the pulse duration is, we are losing the photothermal effect, and we are creating, or we are getting to the photoacoustic phenomenon. So we do not hit the target, we actually break the target. And it is very important. Talking about the PicoWave, we know that we have the highest peak power and the shortest pulse duration. I can talk about many indications, and again, most of my talk will not refer to tattoos removal, but by having high power and short pulse duration, then we can really have a chance, and now I'm talking about tattoos, to really clear the tattoo, to treat colors, for example, blue and green, that we couldn't treat with a longer pulse duration. we can reduce the number of treatment, and we have less side effect. And it is very, very important. I'll start my lecture by trying to refute few myths. So one of the first one that I keep on hearing in many lectures is if you look at the results of nano and nanosecond and picosecond laser, it's more or like the same. And one common notion that if you really want to remove tattoo effectively, you need nanosecond laser and a picosecond laser. So you need a combination. You have to look at the literature, and there are many, many multiple lab and clinical studies that actually demonstrated that picosecond laser are superior in clearing tattoos as compared to nanosecond laser. And it doesn't matter which particle size we have. You can see it in this example. This is four containers which contain particles. They're all being treated with the wavelengths of 1064, and you can see the fluence. This is 2 joule per square centimeters and the same amount of pulses. You have the control, and you have different pulse duration. And you can see that if you have a pulse duration shorter than 1 nanosecond, in this case is the PicoWay, this is 450 picosecond. So it is effectively break better the ink particle as compared to any nanosecond laser. This is just a lab examination, but there are many, many clinical studies that showing an advantage for the treatment of picosecond laser as compared to nanosecond laser. We do know that you need, and you have the references here, we need fewer treatments. So one of the very frustrated phenomena in the past that we use 6 to 16 treatments if we wanted to really get into clearance of tattoos, and we use it with the nanosecond laser. So now we can actually achieve the same result in fewer sessions, and this is very important. We know that we have rapid clearance with the picosecond laser as compared to the nanosecond laser technology. And maybe I think this is the most important. So there was a limit. So talking about nanosecond laser, there was a border, there was a limit that couldn't be crossed. So if we really wanted to eliminate blue, green, yellow color, it was very difficult. So if we want a chance to really clear tattoos, multicolor tattoos, picosecond will perform better as compared to nanosecond laser. The second myth that I keep on hearing is that there is no difference in pain. So again, for the people who experience or who have lots of experience with picosecond and nanosecond laser, this is even not a question. This is a study by Pinto. It was published in the British Journal of Dermatology in 2017, and you can see the very, very big difference. So we're talking about 3.8, we're talking about VAS between 0 to 10, so you can see for the picosecond laser, the pain level was 3.8 in average. You can see this is standard deviation as compared to 7.9, this is the nanosecond. So this is nearly double the pain, and it is quite known. The third myth that I would like to talk about is regarding PIH. We all encounter PIH. Can we compare nanosecond to picosecond regarding the PIH? I'm not sure. So first, for the people who again were less familiar with PIH, this is an acquired condition, and as a physician who treat PIH on a daily basis, it poses many problems. So the patient are very distracted by this phenomenon. It can occur in all skin type, but it is much more frequent in darker Fitzpatrick skin types. So we're talking about 4, 5, and 6. Maybe part of you who sit now in front of the computer, they think to themselves, now in my country, most of the population are not dark skin type. But look at the statistics. So we know that there is cross marriages. We know from different statistics, and this is statistics that were taken from the USA. But we know that by 2060, 60% of the US population will actually comprise of people with skin of color. So we really have to address this complication. So it's not just the patient, of course, it's the laser we use. So different laser are associated with different risk for PIH. We know that if we, for example, use fully ablative laser, it will, if we use it, we have higher risk for PIH as compared to fractional. If we change the parameters, so if we have higher density and higher energy, again, we are more prone for PIH. If we have more treatment, so more frequent treatment, are more prone for PIH. If we have duration, high duration of high pulse duration, longer pulse duration, the patient will be more prone for PIH. So again, in cooling, all the system are usually, or at least most of the system, we're trying to cool the skin before, sometimes during, and of course afterwards, in order to prevent this complication. We know, and again, this is again was published. You can see the references. There are three below. That the chance to develop PIH using the nanosecond laser is 25% in the darker skin type. This is just a general statement. While treated, for example, a pigmentary problem, for example, lentigens, it's not 25%. It actually increases to 47%. So half of the patient with lentigens might develop PIH, and this is a lot. You can see the number of the picosecond laser. We are talking, this is a study that was published this year, in 2018 by Negishi, and it was performed on Asian population, and you can see we are talking about 4.65%. So for sure, picosecond laser are less prone to develop or to produce or to provoke PIH. You can see some examples with the PicoWay, either the Zoom handpiece or the Resolve handpiece. We are talking about easy treatment in general and low risk of PIH. Another myth that I have to address talking about nano and pico, that if you can really if you cannot decide between nano and pico, maybe to buy a system which has both nano and pico. Again, this is something which I cannot really agree with, because the PicoWay system was created to reduce the risk of the nanosecond. So why to actually use both of them? So if you have a system which was created with optimized feature, and it can be used across all skin types, it's very flexible, and you can adjust different parameters, and it has relatively no downtime or very low downtime with minimal risk of hypo or hyperpigmentation. Why to combine between nano and pico? And the question of why maybe to use nano as compared to pico, I want to address the last myth. This is again myth that I have to address, and with this myth I will try to share my experience. Picosecond lasers are not cheap lasers as compared to other lasers, but the question is, and it's always the question, how to use it. So I'll try to share my experience, and although this is one of my cases of tattoo removal, I will not talk about tattoo removal, because I think you had many webinars in the past talking about tattoos, and actually I'm not very experienced in tattoo removal, because the market of tattoos in Israel is not very high. So while having this device, and again I have the PicoWay for I think nearly 4 years, so 3.5 years, with the zoom handpiece and the resolve handpiece and the very very unique uh, um, pattern of tissue injury, what we call the LIOBs. I had to really think creative, and that's what I did. So I wasn't the first one. If you review of the literature, and I'm not talking about tattoos removal, you can really see that many physicians worldwide use picosecond laser for many indications: dermal melanosis, minocycline-induced pigmentation, skin rejuvenation, acne scar, lentigens, venous hyperpigmentation. I will share with you my experience. This is a study that we have just finished, and actually it was sent for publication. It's a retrospective analysis. We recruited all the clinical photographs and information of all the patients that were treated with picosecond laser in the last in a period of 3 years, so between January 2015 and December 2017. All the missing data was completed by telephone interviewed. Whenever we didn't have high quality photographic documentation, we excluded the cases, and because we didn't have many cases of tattoo removal, and we were trying to see if we can actually deduce, or we can have data which indication were treated with this device. We looked at all the non-tattoos indication. So you can see the data that we collected: the diagnosis, the age of the patient, sex of the patient, the Fitzpatrick skin type, where was the location of the lesion, if it was just one lesion, several lesions, or it was an area treatment, the duration of the diagnosis, the device and tip used, the device parameter, if we used any additional topical application, of course, the number of treatment, the intervals between treatment, what was the pain associated, the downtime, and any adverse effects that were reported by the patient. We sent that was something which was very difficult to perform, but we did it. So we sent the before and 6 months after photographs to two non-involved dermatologists, and we asked them to grade the degree of improvement. And you can see the scale. We sent the picture after the telephone interview. We sent the same picture, the before and 6 months after photographs, to the patient, and we asked them to score the same, to use the same score, and to rate the improvement. Of course, we ask their satisfaction rate between 0 and 4, and we asked, because it was most of the telephone calls were performed 6 to 24 months post the last treatment. We asked them if their condition recurred. So I would like you to look at the first table. So these are the results. Again, I'm talking about non-tattoos indication. So we treat altogether, we had 233 patients. You can see the number of female patients, the number of male patients. The average age was 44.3, but again, it was very different, because if you see the cafe au lait macules, the average age was much younger, and when we talk about skin rejuvenation, it was much older. You can see the distribution, so you can see the number of lesions that appeared on the face, on the trach, and generally speaking, I think that it represents the population in Israel. Most of our patients were Fitzpatrick 2, 3, and 4. But again, it represents the population in Israel. Let's look at the indication that are the non-tattoos indication that we treat with the picosecond laser. So we treat melasma with picosecond laser. We treat venous hyperpigmentation, PIH, hyperpigmented scar, stria, acne scar skin rejuvenation, peri-orbital darkening, nevus of Ota, acquired nevus, epidermal nevus, cafe au lait macules, and solar lentigo. You can see the different hand pieces used. So we actually, for most of our patients, we use the Zoom 532. We use a lot the Resolve 1064, and for melasma, we use combined approach. So you can see we use, you can see this is the bottom line. You can see we usually use, and you will see the parameter and the rationale behind the parameter. So we use Resolve 1064 and a combination, not for every patient, but we use the Zoom 1064 or the Zoom 532, and we use other modalities. I think only for the treatment of tattoos, we use the Zoom 1064. You have the number of treatments, and you have the interval, the average interval between treatments, so you have all the protocol. I'm getting back to the effectivity or the efficacy of the treatment, and again, I remind you the scale between 0 to 5. So, if you look at it, you're trying to grade it in or to put it in a decreasing order. So, in our clinic, acne scars or the treatment of acne scar with picosecond laser, it wasn't very successful as compared to the treatment of epidermal nevus or cafe au lait macules. But you can see that you can treat many indications. So again, if you do have the PicoWay, it's not just tattoos. Let's go into the different indication, and I'll try to share with you the different studies we performed and the different protocols that we use. So the first indication that we and I think we have really nice success with this indication is the treatment of epidermal nevus. This is a publication that came out a year ago. It's a publication that was performed by the group of Professor Moshe Lapidot and my group. And you can see the patients, and you can see all the demographics, the number of treatment sessions. And generally speaking, we're talking about picosecond 532 nanometer, the zoom laser. We needed in a 6 treatment session, but you can see that there it's up to 6 treatment session. So we had patients with less session, but it's not one session with 8 to 10 weeks interval, and you can see the setting. The rationale behind this treatment, and we are trying to really separate, so to use these LIOBs or to use this separation, this blasting, this acoustic effect in order to separate the epidermis and the dermis, and in order to separate it in a clean way. I'm a CO2 laser guy. I treat CO2 on a daily basis, and it's very, very difficult to be accurate and not to replace the epidermal nevus by scar. And I think we had really nice results. This is one of the cases from the study. This is again one of the cases from the study. And this is my case. It wasn't published in the study, but you can see when you have a very, very thick verrucous epidermal nevus, first I remove it with the CO2, so the bulky area is removed by CO2, and all the rest are removed with the Picosecond laser. And then you can achieve, and I think you can appreciate the final result. Again, you can achieve a very, very good result. Let's go to the second indication. We were really surprised with the result, the cafe au lait macules. Again, this is a publication by the 2 groups that were mentioned previously. You can see the patient altogether. We had 16 patients. One patient did not respond to the treatment, and we tried again and again, and it was dropped from the study, and it is not included in this table. But you can read all. It was published, so you can read all the details in the publication, but again, we're talking about the Zoom handpiece, 532 nanometer. You can see the parameters, and we have really, really good response. Again, the before and after, different ages, before and after, before and after. You can see the before and after, and we try to review the literature. And I started by talking about nano as compared to picosecond laser, and I talked about tattoos, but I think I can say it about cafe au lait macules as well. So if you compare our result to the result that were accomplished by Q-switch laser, so with picosecond laser, it is more effective and the recurrence is lower. Let's go to the third indication. So solar lentigo, I do not think you really need to buy a picosecond laser in order to treat solar lentigo. So if you have an IPL, again, this is a good device to use for solar. It depends which and how big is the solar lentigo, but generally speaking, lentigens can be treated with different modalities. But if you do have the PicoWay, we have, and this is our protocol, we use always a combination of Resolve 1064 and Zoom 532, and we usually apply tretinoin 5%. It's not a mistake, it's not 0.05%. We use it just once. It's a special compounded formulation. It's actually a superficial pill, and with this protocol, we have very, very nice result. I would like to talk to you about hyperpigmented scar. This is my main focus. I'm the chairman of one of the biggest scar treatment conference. The last one was held in Tel Aviv. And I think that if you would like to treat scars, you really have to look at the scar as if it was a picture with different colors, with different elevations, with different depression, and each component of the scar should be treated differently. So if you have a red area, erythematous area, this should be treated by different vascular laser, for example, the pulse dye laser, the V-beam. If you have an hyperpigmented area, it can be treated by thulium, it can be treated by Q-switch, it can be treated by IPL. You can find different references in the literature. If you have a trophic area, you want the tissue to be remodeled. So you can use either ablative or non-ablative fractional laser. And if you have a hypertrophic area, you should usually use ablative fractional laser. You can use different laser, but ablative fractional laser with or without the injection of, I would say, drugs, mainly triamcinolone or and 5-FU, will provide you with a very, very good aesthetic outcome. I would like to share with you a publication that is about to be published. It was accepted for the publication a year ago, but is still it still waits to be published in the Dermatological Surgery. It's a retrospective case series of 16 patients who had scars, but the main component of the scar was non-improving hyperpigmented component. You can see the parameter in these cases. We used the Resolve 1064, and you can see the energy. And in order to be very objective, we instructed our patient not to apply any other anti-scarring or anti-bleaching treatment in order to really see what is the impact or the effect of the result, the picosecond laser. We followed our patient up to 6 months after the last treatment. And in order to really measure the change of melanin content, we use in our clinic, we use the mixameter. So again, for the people who are less familiar with this device, it gives a number. You have a number which quantifies the melanin content of before treatment and after treatment. We had our scars, our patient photographed, and we send the before and 6 months post-treatment photograph to two non-involved dermatologists. You can see the scale here is between 0 and 4, and we ask our patient for their satisfaction between 0 and 3, the tolerance, downtime, and any adverse effects. So you would be able to read. I hope it will come out soon in the dermatological surgery. This is the table from the study, but you can see this is all the details of the patient, the scars, and the treatment. You can see the average age of the patient was 33.1. We had all skin types. You will see the pictures in a second. Generally speaking, the average number of treatment was 4.18. It ranges between 3 and 8, and we are talking about a 4.5 week interval. Please have a look at the change. So if you look, and I marked it down for you, so if you look at start with the objective measurement. So after the treatment with the result with the picosecond laser, we have an average of 39.6% improvement in the melanin content, and you can see the average GAS of the physician. And again, our satisfaction or the satisfaction of the patient were quite high. It was very, very well tolerated, and we didn't encounter a significant side effect. This is one case that I was very proud of. This is a very dark. This is an Ethiopian lady, and this is kind of a traumatic tattoos, and you can see that it's a combination of atrophic scar and hyperpigmentation. So here we performed the resolve together with the injection of some filler, and you can see the result. And again, the before and after, you can see the results are quite impressive. So again, this is one of the indications that I really like to use. Do I use it as a monotherapy? No, because again, every scar has different components. So we look at the scar as if it was a picture. We have different colors, we have different topography, and you should know how to treat every component. But nowadays I can tell you that the hyperpigmented component of a scar can be really improved by the use of Resolve or the Picosecond 1064 nanometer 1064 picosecond laser. So this is the four first indication. I would like to mention, and I'll do it more briefly, two last indication. One is melasma, and one it's the peri-orbital darkening. Those two indications are very, very difficult to treat. Let's start with melasma. So I believe in every conference you went for, you heard about melasma, and you read many articles, many publications about melasma. And so we talk about melasma, and we see so many patients with melasma. This phenomena, this disease is a chronic disease which only partially responds to any treatment, and we know that even if we improve melasma, it tends to recur. If you look at the literature, nearly every laser in the market was actually proven to improve melasma. IPL, the Q-Switch Ruby and Alex, the Q-Switch NDIAC 1064, which is very popular mainly in Asia. There is a huge concept called laser toning. They use it in focused and in defocused mode in different setting and different parameters. The fractional lasers, which are actually FDA approved for the treatment of melasma. This is a recent publication. The use of thulium plus hydroquinone, which was better as compared to the laser. The use of pulse dye laser for the vascular component of melasma, because we do know that melanocyte express VEGF receptor. We do know that we have upregulation of many, many vascular components in melasma. So this is again uh, uh, one, I would say, direction. So many, many lasers. If we look at the new kid on the block, it's not very new, but from 2012, in the last 2 years, there are several publications regarding the use of picosecond laser, and they use the photoacoustic effect in order to uh, kind of move the pigment, dissolve the pigment. This is a very, very recent publication from actually a month ago, November 2018, and it compared between picosecond and nanosecond laser, and it showed that the picosecond was more effective, had faster and better clearance rate as compared to the nanosecond Q-switch laser. However, while talking and usually ask if I really think lasers are the answers or are the main answer for melasma, I think that we have to be humble and we have to confess that if we talk about melasma, the situation and this condition in general, it is much more complicated that we know. So we know a lot, but I'm not sure we know what we do not know. What we know, and I'll try to share with you some concepts that are known. We know that, for example, there is an increase in the melanin synthesis and there is an increase in the number of melanosomes. But do you know that there is a change in the basement membrane between the epidermis and the dermis? So there is vascular degeneration of the basal cell. We have degradation of the heparan sulfate chain, so many growth factors actually travel between the dermis and the epidermis, and they will stimulate melanogenesis. We know that the disruption of the basement membrane, usually due because of chronic sun exposure, it will it will push melanocyte into the dermis. So again, we have melanocytes, which are more active in the dermis and they produce melanin. The dermis is changing. We know that we have extracellular degradation and we have solar elastosis. This is a phenomenon that we see more frequently in melasma patients. So we have many melanogenic cytokines who are getting into the epidermis or stimulating hyperpigmentation of the overlying epidermis. We know, and this was mentioned previously, that we have an increase in the number of blood vessels, but it's not just the number. We know that there is a change in the size of the vessel, in the density of the VEGF. I'm not sure you know, but I'll mention it. There is an increase in the number of mast cells, and actually there is one publication who state that this is the first and the main phenomena who stimulate melanogenesis and actually provoke melasma. So do you really think that by using just one modality, one specific laser, we can solve all the problem? So if you really want to help your patient, there is no one modality that should be used. So the directions are five. You first degrade the melanosome or suppress the melanin synthesis, but you have to reduce the vascular component as well. You have to restore the basement membrane or the extracellular matrix. You have to somehow downregulate the melanocyte, so to calm down the overactive melanocyte who wants to produce more and more melanin upon stimulation, and you want to decrease the number of mast cells. So again, I'm not sure I'm having, I would say, perfect result, but I hope my results are better. I do use the picosecond laser in order to treat plasma, but I use it just as part of a full picture. I use the picosecond laser in order to break down the melanosomes. I use it the picosecond laser, and you will see the parameters in a second. And I use pills. I use pulse dye laser in order to treat the vascular component. In order to restore the extracellular matrix and the basal membrane, I use different fractional laser. I really like to use the Resolve because of the very unique tissue pattern, the pattern of tissue injury, the LIOPs that we discussed in the beginning. We will have an acoustic effect with nearly no thermal effect, which will provoke tissue remodeling. So we're going to have some reconstruction. So we're going to strengthen the structure and to prevent the influx of cytokines and other stimulation from the dermis to the epidermis. In order to reduce the number of mast cells and to decrease vascularization, I really like to use tranexamic acid. I like to use it orally. There is a very big publication came out a month ago in the JAD. The title of this publication is The Game Changer, Oral Tranexamic Acid in the Treatment of Melasma. I think if you deal with melasma, you should read this publication. If your patient cannot really take oral tranexamic acid, you should somehow find a way to deliver it. So I use it. My patient, if they cannot take it, I use the laser-assisted drug delivery, and I topically apply tranexamic acid in order to provide them with this drug. I use different formulations. So I use the triple combination, and if the patient cannot take it, I use the hydroquinone or azelaic acid. Not to begin with, I use it if I want to prevent recurrence in order to decrease the melanin synthesis. And generally speaking, I want, as I've said, I want to down-regulate the system. So I want to create an environment in which melanocytes are calmed down and they're not producing much melanin. So you can use, and again, this is few applications that came out in the last 2 years. You can use different LEDs in order to photobiomodulate the situation or the condition. You can use steroids, you can use pulse dye laser in a very, very low setting. So it's again, it's a picture. You have to formulate a treatment. So do I believe in picosecond laser in the treatment of melasma? Sure, it's not the only modality. You have to use a combined approach in order to try and to reach a better solution. You can see the before and after and never believe pictures. Always ask what is the time frame between the two pictures because you can really improve melasma with IPL. The question is what would be the percent of patients that will have recurrence. Again, before and after, this is 12 months apart. And again, I'm not successful with all my patients, but I hope that I am more successful. The last indication, and I think with that I will finish and I will answer some questions. I will talk about peri-orbital darkening. So again, this is a complicated indication because when the patient comes to us and he or she complains about peri-orbital darkening, we really have to look what is the diagnosis. Do we have tear trough deformity? Do we have true, so if we stretch the skin, do we have true hyperpigmentation? Do we see tissue laxity? Do we see prominent blood vessel? Maybe it's fat herniation or hypertrophy of the orbicularis oculi, because different etiologies or different problems require different solution. You can see the first line treatment for each, I would say, etiology, and you can see the second line. I really like to use the picosecond laser when I have two components, hyperpigmentation and tissue laxity. I'm not the first one to use the picosecond laser for peri-orbital darkening. These are the two publications that I found regarding under eye pigmentation or infraorbital dark circles. But again, I was very happy to see that I'm not the only crazy guy in the neighborhood. But this is my protocol. So I believe that peri-orbital darkening, it's usually a combination of vascular pigmented and pigmented component and tissue quality. So I usually use these two devices. I use the V-beam. You can see my parameters, and I use the PicoWave. I use the zoom handpiece, but in a very low setting and large diameter spot size. You can see the parameter, and I think I have really nice result. If I have tear trough, and this is always my first step, I usually use some hyaluronic acid. I usually go for very low G prime. In this aspect, I really like um, there are different fillers, so I'll try not to mention it, but do not use high G prime AJ-based fillers. Again, before and after, here you can see some filler, pulse dye laser and picosecond laser, the zoom handpiece, and here is just the pulse dye laser and the picosecond laser. Again, you can see parameters of the pulse dye laser and the different parameters of the PicoWay. I think I will stop here, and I will leave some time for questions.
Terrific. Thank you so much, Dr. Artzi. At this time, we have a few questions that have come in for you. The first question is, do you use a nanosecond laser for anything in your practice, or do you just use your PicoWay?
No, I don't. In my practice, I have again, I have different, I have I have three, I would say organizations that I work in. So I've got the hospital in which I do not have neither Pico nor Q switch. I have my Jerusalem clinic in which I have the Picosecond, and I have my Tel Aviv clinic in which I have Q switch. So in every facility or in every would say organization, I have different modalities, but I do not think you need to use both. So I would say that as far as I concern, picosecond laser provide me the best tool as compared to the Q switch laser or as compared to IPL. IPL, I use it for different indication. Q switch, if I have the picosecond laser, I would not use the Q switch. But again, it depends on which, in which place, in which office I'm in. Different offices have different modalities and different devices.
Great, thank you. The next question is, do your pigmentation patients experience any downtime with PicoWay?
Yeah, sure. If you go for, it depends. If you use the Resolve is a very safe and very easy treatment. And the downtime is, I would say, nothing to very minimal. If you go with the zoom handpiece, the 532 handpiece, and I'm talking about now the lentigens or let's say flat seborrheic keratosis, so you have downtime. So you have downtime of approximately 1 week. We usually show pictures to our patient, but again, this is a downtime. I believe in downtime. Downtime is okay. So I usually tell my patient that if you have a treatment which has no downtime and it doesn't cost money and sometimes it's not painful. Talking about that for the zoom handpiece, it's a downtime of 4 to 7 days, but it's not a very I would say severe. So the adverse effect and generally speaking, the downtime is not so severe. So it can be you can use makeup. They can go out, maybe not in the first 2 days, but it's a very easy recovery.
Great, thank you. Our next question is, have you ever used PicoWay in a type 5 or type 6 patient?
Yeah, I showed you some example. I have no problem to use it. The Resolve, there is really not a problem to use it. And I have to say that I did use the 532 even in Fitzpatrick type 5 and 6. But again, I can tell you that, and I showed you the representation of or our numbers. We try to see how many patients we treated with the PicoWay and which Fitzpatrick skin type, and for some reason, and maybe it reflects the Israeli population, but most of our patient is Fitzpatrick 2, 3, and 4. So we have patients with Fitzpatrick 5 and 6, but they're very very rare. So and it's for every indication. So you could have asked me the same question regarding radiofrequency. Probably I would provide you with the same numbers.
Hmm.
So we treat most of our patients. They're Fitzpatrick. They're not. They don't have Fitzpatrick 5 6.
Got it. Great. Thank you. And our last question that we have right now, when you use PicoWay and V-beam, which do you typically use first?
That's a good question. In the beginning, I used to I used to try to do VB first, followed by the picosecond laser. Now I'm trying to actually not do the pico the V beam and the pico way at the same treatment, and then it depends on the indication. So regarding scars, and which is a totally different world. I do use them at the same session, but again, I have different components. So let's say I have the vascular curve. Whenever I see red, it is treated by the VIVIM, and not at the same area I treat with PicoWave. And sometimes I use the laser-assisted drug delivery, the CO2 laser-assisted drug delivery afterwards. So I use different lasers in the same setting. Regarding pigmentation, nowadays I'm more careful. I usually use it in different settings, especially what I showed you with the Peri-Orbital Darkening. So this is two different settings. And regarding melasma, we use it in different settings as well. So we use first the picosecond laser in order to first eliminate, to degrade the melanosome, and then in order to reduce the vascular component, we use the pulse dye laser. Again, different setting, different visits.
Great. Thank you. For all of our attendees, we want to thank you for joining our webinar program today. We will be sending a follow-up email with this recording, and if you have additional questions or would like to learn more, we will be happy to connect you with your local representative. A very special thank you to our special guest speaker, Dr. Artzi, for your informative presentation and for sharing your valuable knowledge with us. Dr. Artzi, any closing thoughts for our attendees?
No, it was great sharing my experience and my thoughts, and I hope everyone took at least one idea, and this is the most important from every learning.
Perfect. Thank you so much. We appreciate your time and valuable insights that you have shared with us today.